and it's great to see you all. So first of all, Sabina, Mustafa, thanks for the invitation. I am going to just switch off the camera because it's just told me the Wi-Fi isn't working too good, but hopefully you can hear me okay. And really, I wanted to tell you about some of the work that we've been doing. My apologies to all of you who've heard me go on about the importance of public health. And one of the key things that we've always been particularly important to stress is about community engagement in everything that we do, and moving away from tokenism for the way that we engage with our communities to real partnership work. And so we feel this is the real change that's needed if we're going to start looking at how we actually tackle inequalities, not just here in Greater Manchester, but also nationally and globally. I'm sure many of you have read the Levelling Up paper that was recently published, as well as the other white papers. And it's important to remember how much of the policy agenda now involves not just for health, but well-being and all the determinants of health and well-being on the role of digital. And it's something that we can't escape from. And so a lot of our talk today is based on some of the research that we've been doing, some of the research that we've been collecting in terms of looking at the literature, and also from talking to our communities, both nationally and globally. And what we've come up with, as Sabine kindly mentioned, is a range of different ideas to try to reduce digital exclusion in the modern era, and our part, either as academics or healthcare professionals, working in communities, and really focusing in on the fabulous resource that we have in our local authorities via the directors of public health, via our public health teams and the public health intelligence teams that I'm sure many of you already work with, and the huge opportunities that we've got now in terms of thinking about inclusive research and how we build in reduction of the excluded populations by thinking around inequalities. So my talk today is a little bit of a demonstration of inequalities from different perspectives. And then, as Sabine mentioned, our work with policy at Manchester. And just a shout out, if any of you are in the faculty, I'm the representative, and so if anyone's interested in any of the policy work, my email address is here, and Callum Woods and I will be doing a roadshow around the faculty also. So really keen to hear your thoughts and to work closely with the Christabel Pankhurst Institute, because we think this is so important for the 21st century. So just to have a look at some of the work that we've been doing, and this is work from Greg Williams, one of our lecturers, and This is looking at the years of life loss due to COVID, and it's really a function of age and also the population distributed. You'll see here that England and Wales are second only to the US, and what we are really focusing on at the moment is looking at how we devise the interventions needed for reducing the impact of the inequalities that COVID has actually brought to the surface, which includes the fact that we're working from home more, that we haven't got all of our households, especially, and it's so good to see Chris Todd here, the older population, and also people from low socioeconomic households that may not have even access to the internet in terms of being able to access what is possible in terms of health and well-being resources. And so much of healthcare was converted onto digital platforms during COVID. How do we actually get the inequalities associated with how we're now doing new NHS solutions into the places that need it the most? I'm sure many of you have used the Index of Multiple Deprivation. This GIS map just looks at the deciles of deprivation that's colour-coded across Greater Manchester, Cheshire, Merseyside, Lancashire. And one of the key things that I really wanted to say during our time together is to bring up the IMD, which is a fabulous resource created by the Office of the Deputy Prime Minister when John Prescott was the Deputy PM. It tried to bring together different domains that would then be able to be used at lower geography areas to look at deprivation. And I think a lot of the work that went into this was really helpful in order to look at deprivation as an index that you can then utilize in models to try to explain deprivation in terms of either risk estimates or looking at how interventions can ultimately reduce risk. But one of the key things that I think is important to say about this indicator is something that we always talk about to our master's students in terms of ecological fallacy and the importance of not ascribing deprivation that's an area-based statistic to any individual as well, and being able to not just think of IMD as a resource that because it's easy to get, easy to then put into your models and easy to use as a proxy for deprivation, that it is then equatable to something that is at individual level. The other problem with IMD, you can't really compare it to even IMD for the other countries in the UK, let alone international comparators due to the domains that are used. So there are issues with IMD that I just wanted to highlight. The other indicator that we've been working on is avoidable mortality. So this is something that we looked at as part of our European health indicator system, and also as part of our response to COVID, in terms of what does it actually mean. So this is an indicator, again, created by the Office of National Statistics, and it's really helpful because what it demonstrates are those deaths where we actually have either a healthcare or a public health intervention that would have avoided that death. And the reason for bringing up this slide is just to show our intra Greater Manchester differences. So just to show you some of the graphs, England slightly massed down here that you can see with the red line with the blue dots. And then we've got our northwest figure that runs down here. And then you can see right at the top is the Manchester rates. And approaching England, we've got Trafford and Stockport. And the good news is we haven't got data during COVID. So the current data set stops just before the pandemic, but the trend was going down, and the gap between 2001 and the 2017 to 19 data has reduced, and all of our areas have been dropping. And this is work that was done by our colleagues in Liverpool that looked at local authority data. And this was recently published that showed the difference between funding and IMD in terms of being able to see the differences between how much funding cuts were achieved by each local authority. And I'm sure you can see here that what we've actually got is a higher rate of reduction of funding in the most deprived areas, and showing also over time that inequalities have widened. And being able to really think through digital inequalities with our local authorities who may not have as much resource as some of their other local government partners is really important for us to think through when we're looking at how to address that digital divide. And I think I always bring up Tudor Hart because even 51 years later, we're still talking about an inverse care law. And it doesn't matter if, I mean, this was written about primary care, but I think it's the same for the digital spread of what people need to be able to have a fulfilling life in order to improve their health and well-being, which includes digital interventions. There's an inverse care law with that as much as any other part of healthcare services. The other work that we're doing with WHO has focused on looking at information systems and developing with WHO Euro how we actually look at the success of interventions. And as you all know, Health in All Policies has been around for over 40 years and called on the public health, primary care and secondary care sector to think about how we do intersectoral actions. And so if we're going to look at digital solutions, what we found in our policy analysis, looking at international evidence from low and middle income countries together with high income countries, is it really didn't matter which type of policy you were looking at. The key goals that we really needed to focus on can be incorporated into thinking about leadership and coordination, and thinking about then how this policy needs to interact for the digital revolution to ensure that we can try to think about all the issues that are affecting health, from climate change and the environment all the way through to the social and wider determinants, are really important in terms of individually orientated preventative actions. And these were certainly part of the drivers for some of the policy documents that have been recently updated, and very much are inclusive of how we that work in either digital health or public health that requires a digital intervention, or the utility of our populations to be able to use digital interventions. The key policy documents have included how we can do that. And obviously that includes the Sustainable Development Goals. And I think for many of the health and well-being indicators that make up the SDGs, digital and being able to provide digital solutions feeds in to all of the core components of the SDGs. And some of the work, again, that we're doing internationally, looking at how that global inequalities issue post-pandemic can be addressed through digital solutions. And that leads us on to something that we've been talking about for some time, and sadly, Professor Hanlon's website at the University of Glasgow is no longer active, but I always bring this up because of the huge implications of how we look and think about digital inequalities in terms of something called modern public health. And the discourse that Professor Hanlon really describes is that if we carry on doing public health in our case, or health in the traditional sense, we're really missing all of the key drivers that our populations are being influenced by. And one of the key things that I learned from reading around the text that he very much brought to the surface is that the people that influence the people that we would like to influence isn't us. And so true partnership work is what we need to do to be able to really start to address inequalities. And again, this led to some other pieces of work that we fed into Public Health England as was, which basically looked at some of the key components of behaviour change. Where sometimes it was at odds with health promotion practice and the theory behind health promotion, in terms of sometimes from speaking to our populations, it felt like to them what we were saying was there's something wrong with you, and we have the interventions, be it digital or other, and by doing this, we can make you better. So that deficit approach has been something very strongly advocated through things like the behavioural science unit and nudge. And we were taking core components of that to use with an asset-based approach. So this work actually was done by Judith Clegg and Andrew Rogers, and basically what we did was talk to communities and then work out what was important to them. And in one particular area, the most important asset was their takeaways. It was where people met, it was where they exchanged information, it was where they got to find out what was happening in the area, and also be able to share stories and build social capital and cohesion. And so using that asset-based approach was how we devised some recommendations for the local authority to be able to then have a closer intervention with their communities via their takeaways. I'm sure many of you have seen the rainbow model, the Dahlgren and Whitehead model that was created for WHO has been adapted by our colleagues at the University of the West of England. And the reason for bringing this in is to really talk about inequalities being a function of mental and social well-being being lost. And I know many of you will already be acutely aware of the cost of living crisis that's going to hit our populations. And one of the key things that we're now currently investigating is looking at all of the tsunami of effects that are happening to our most deprived populations following the pandemic, and all of the core components of losing household income due to a variety of different factors, and being able to think about how digital solutions might actually reduce inequalities. And some of the work that we've been doing involves community engagement. And I'm sorry to keep bringing up evidence from multiple decades ago, but it applies now even more than ever. And I'd just like to, if you haven't already read Einstein's Ladder from 1969, I can say it's as important now as it's ever been. And moving away from tokenistic community engagement is one of the key things that we've been trying to do, and thinking about how we communicate with our populations for inclusive research, so that they're involved in the planning, the design, as well as the implementation of our research, of our policies, and being able to not only get the usual community anchors, but actually engaging with the other layers of our communities who don't always volunteer to take part in either research or PPIE, is one of the key components of some work that we're currently doing on inclusive research. And certainly the need to really think about need has come up. Again, with inequalities, including digital, it's very easy to measure demand because that individual has created a data point, and that data point is often now recorded in everything from your primary care or secondary care record, or your social care record, or if you're doing surveys, those people have already for some reason, perceived a need to either complete a survey, seek out services, be able to navigate the system to create a data point. What we're saying is, even though this will be the majority of our populations, especially in Greater Manchester, there's a huge wave of people who do not access services. They won't be creating a data point in any of our major health systems and care system records. And so working with local authority partners to go back to Public Health 1.0, which is to actually create a way of measuring needs. And one of the first steps is community engagement. And we can think about community engagement in a number of different ways. And for our digital exclusion work, we used a number of different routes. And what we found from our systematic review was it didn't actually matter which methodology of community engagement you use, as long as it was true engagement and not tokenistic. So we have done different forms of engagement, including appreciative inquiry and the asset-based community development approach and the place-based approach. And this was especially important because of the need to really think through the digital interventions that were needed to support local action on how people were going to address health inequalities. And this has led to a couple of publications that were done for Public Health England. And I think one of the first things really to say is to think about that whole governance system and look at a whole systems approach if we're going to tackle health inequalities through making better use of digital interventions and reducing digital inequalities. So this was work that we did last year from a consortium development grant, and like to thank our colleagues that worked on the prior study with us that was part of the UKPRP action for reducing inequalities. And so what we wanted to do in our consortium development grant was think about how we reduce inequalities in 3 of our most deprived communities across the north. And what we found out from co-producing the first proposal with our populations is the things that they were worried about. And those obviously included financial and health and well-being, but right at the centre of all of this was the digital side of things. So our communities know, even if they don't have access to Wi-Fi or the internet, it's one of the most important things, not just for them, but for their children. And being able to have those opportunities to improve their lives. A lot of the work was looking at how the digital side of things would help in that area. And so we came through to try to describe a whole systems approach. And in this particular call, it was all about reducing non-communicable diseases. And so we came up with our partners and our community champions on this model that would basically focus on trying to think through digital, financial, health and well-being via different components of the community, which included inclusivity of digital interventions, and then how those things then will impact on social determinants that would then impact on outcomes and therefore the individual. And the work that we did, please have a look at our website. We basically, and this is probably no surprise to any of you, showed that inextricable link between digital health and financial literacy in terms of how we look at being able to reduce health inequalities. We've got to focus on all three dimensions. And that led to Policy at Manchester kindly helping us with disseminating some of our work and basically thinking through with a lot of great partners how we basically shouldn't leave behind the most vulnerable, and quite the opposite, thinking about how we ensure equity by having more resource for the vulnerable so that they're not left behind by the digital revolution. And Better Points and the Good Things Foundation have been absolutely instrumental in our work, and being able to work with them has really helped. And just taking that right back to the beginning of the talk, it's so important. We were doing this just across the north of England, but the importance of this in terms of everything from climate change and the impact of the environment, looking across the life course, so thinking about the best start in life, thinking about what we do with our working age populations, and then our older adults is absolutely fundamental in terms of the digital divide that we're currently creating, and doing things differently is really important for us. And that's why it's so exciting to be working with you all to try to think through how we actually address these actions, and hope that what we've demonstrated is the importance of working as a transdisciplinary team and thinking about these issues in terms of working with partners. And so I'd like to thank all of the various teams that have helped us in our journey, and also just to say that our master's programme has a lot of different components of what we've talked about, including a really successful digital public health course unit. We've also got free open access CPD through our initiative via the i3HS hub. These include some open access on inclusive research that was kindly designed by Bella Starling from Vocal, who's done fabulous work on how to improve inclusive research, including the digital divide. And just to invite you all to either submit an abstract or come and register, because it's our 10th Festival of Public Health this year, and we've got some exciting speakers already that we're going to announce soon. So please come and give us your thoughts on how we can together bridge the digital divide and reduce health inequalities by reducing digital inequalities. Thank you ever so much.